Good morning and welcome to the Common Part B Pediatric Medicine Rejections and Denials webinar. I am Mary Mucko. I am a member of the WPS Provider Outreach and Education team, and I'll be your presenter today. Joining me is my friend and teammate, Bailey Lawson. Bailey will be assisting with some of the behind-the-scenes help. This webinar today is for those people who are wishing to learn a little more about the most common reasons for rejections and denials on Part B claims that are submitted to WPS by Specialty 37 Pediatric Medicine Specialists. Now, you may be wondering why we chose this topic. CMS actually requires all of the Medicare Administrative Contractors, or MACs, to include education about common rejections and denials, and we're doing so in order to prevent future claim rejections and denials. And just as advertised, the information that I will be presenting to you today is based on actual WPS claims data. A little bit of housekeeping first, though. This presentation is available for download from our live events webpage. The webpage address is in the chat. You may take time to download the materials now if you've not already done so. We are recording this session. Barring any technical issues, we will post the recording on our Encore Presentations webpage, where it will remain about 60 to 90 days. The recording will also post on our YouTube channel, where it will remain as long as the information remains current or until we otherwise determine a need to remove it. Now, if you have questions, please place them into the chat. Bailey will be monitoring the chat. I do plan to answer questions as time permits. If I don't get to your question, I will email the response following today's webinar. I will send an email directly to the learner that posed the question, or I'll prepare a list of questions and answers, and I'll share them with all of the participants in this session today. I am unable to provide answers to claim-specific questions. I don't have access to the claims processing system. It is in CMS directives that the MACs are told that claim-specific questions must be handled in customer service. So you can certainly ask a claim-specific question, but you'll need to direct that question to customer service so they have access to those claim details and claims history in order to help you and answer your question. Now, we do include a disclaimer in all our live events. I made every effort to verify that the information that I'll provide is current and correct, but it is subject to change. It is on the CMS website where you will find those Medicare rules that determine final coverage, and these laws, regulations, and rulings will always prevail. And finally, CMS prohibits recording of this webinar for profit-making purposes. We don't know how you'll use a recording, so we just ask you to refrain from it altogether. Remember that we do create an encore of the presentation. Encore is just another word for recording, and you may use that for future reference. Based on the American Medical Association's copyright notice for CPT codes, descriptions, and other data, I have included this CPT copyright notice in my presentation materials, and I'm showing it to you now. Your continued participation in this webinar infers that you agree to the terms of the copyright notice. Here is the agenda for today's webinar, and it should look really familiar to you because this is exactly what I advertised I will cover during today's event. When you registered for this webinar, these are the exact words that you would have been able to read in the description of my webinar. Today our goal, or my goal, is to share with you the most common reasons for claim rejections and denials for pediatric medicine specialty claim submissions to WPS. I'm going to define rejections and denials, reveal those reasons for the most common rejections and denials, and that's based on actual claims data that I pulled and analyzed. And I'll also discuss ways to fix and avoid these specific rejections and denials I'm talking about today. And I'm going to provide you with many, many resources. When you registered for today's webinar, you had an opportunity to tell us what's that one question that you would like us to answer during today's webinar. And I didn't get a lot of questions, but I did get a lot of comments saying you just really want to know what are those most common reasons and rejections. Reasons for rejections and denials, rather. Now, this is a lot of information that I have in 60 minutes with you today. I am going to be moving quickly through the slide deck. I may ask you to review some of the information following today's live presentation. There is a lot of resources included at the end of the presentation. So those are pretty self-explanatory. You'll look at what's on the slide. If it's something that you will find helpful in fixing or avoiding those rejections and denials I'm going to talk about, you can just simply click on that link that I've embedded in your presentation materials, and it'll take you right to that resource. So if you have questions, again, I will tell you later on how you can send them to us, and throughout the presentation, you're able to use the chat to submit your questions. So in order for me to discuss rejections and denials, I do need to provide a little bit of information about the claim process itself. Now, based on a law that requires it, makes it mandatory, most providers must submit claims electronically. There are reports that generate, and these confirm claim receipt. There's actually edits when claims come in the door, if you will. We call these pre-pass edits. One of the reports that you can receive to make certain your claim is received is the 276-277 report. We do have companion guides that were prepared by our electronic data interchange staff that will clarify, supplement, and define that data content when you submit your claim file to WPS. And it will also tell you whether you need to correct or resubmit it. Again, these were prepared by our EDI staff, and it is on our EDI webpage, which is a separate website from WPS's website, but you can get there from here, kind of thing. You can get there from our website. It is on the EDI website where you can find these companion guides and other really helpful information that our EDI staff has prepared, so you understand those claim requirements and you know when you need to correct or resubmit the claim. Now, claims that move past those pre-pass edits, they make it in the door, if you will. They're going to generate a remittance advice. We also refer to this as the RA. Some people call it the notice or the remit. Some people simply just call it the notice. There are two formats. There's an electronic remittance advice. This is the ERA. And there's the standard paper remittance, or the SPRA, and with few exceptions, most providers are receiving that electronic remittance advice, or the ERA. Now, that remittance advice provides really important information to the provider for adjudicated claims, those that are actually processed. You can find information about adjustments, denials, maybe a claim line denial as opposed to the entire claim, missing items, refunds, and sometimes you'll even find information on that RA about offsets. Now, when you're looking at the remittance advice, you're going to find various reason and remark codes. These are typically in an alphanumeric format. Now, when claims pay differently than they were billed, a claim adjustment reason code appears on that remittance advice. And sometimes a remittance advice remark code also appears. And remark codes actually just expand on those details that are described by reason codes. And they do so in order to provide more details about the adjustment to that particular claim or claim line. Now, another type of code that you'll see on the remittance advice is a group code, and group codes assign financial liability for any unpaid balance on the claim. A CO group code stands for contractual obligation, and when you see this on the remittance advice, you know that the provider is liable and cannot bill the patient. A PR group code on the RA means the patient is financially responsible. Now, WPS hears a lot of comments about these remittance and remark codes. Providers often state to customer service in conversations with them that those remittance remark codes and reason codes on the RA are really too cryptic, or that they contain outdated acronyms. While we'd really like to help, it is another contractor, not WPS, that maintains these codes for CMS. You can find a link to the code lists on the Washington Publishing Company's website. It is on their website where you can find contact information should you wish to suggest a change to any of the code lists, including those code explanations that I just talked about with you. Now, this is an important slide because it really shows you or compares a rejected claim to a denied claim. They are very different things. It's important for you to understand that in order to know what you need to do to correct the situation, the denial or the rejection. On the left side, you'll see listed information that pertains to a rejected claim. A rejected claim is not adjudicated. It is unprocessable, and that's what CMS calls rejected claims in their internet-only manuals. These are what we like to call returned on the front end. They're not processed, they're not adjudicated. They're unprocessable. And the reason why they are unprocessable, or a claim line is unprocessable, is something's illogical. Something may be missing, or it may be incorrect. Because rejected claims or unprocessable claims are never adjudicated, there are no appeal rights. You need to fix it and resubmit it. When looking at the RA, if you see an MA130 or a CO16 code on that RA, it should be a flag to you that notes that this is a rejection. It's unprocessable. The patient is not liable. You need to fix it, resubmit it. A denial, on the other hand, is actually adjudicated. Medicare will deny services for a number of reasons. There could be a law or what is called a statutory requirement for denying a service. The service could be denied because it doesn't meet Medicare's medical necessity requirements. Sometimes these are published in a policy. Policies equal edits, and those edits are looking for medical necessity. Frequency or utilization parameters are a form of medical necessity edits. Eligibility is another reason why Medicare may deny a claim. It could be that the patient isn't eligible when the service was rendered, or it could be that that provider is not eligible to bill Medicare or bill Medicare on that data service. When you look at an RA for a denied service, there will be various reason and remark codes to explain why the service was denied, but you'll also notice most often, there's few exceptions, an MA01 code, and this is what provides your appeal rights. Most claims have appeal rights. There are some exceptions. And of course, for a denied service, patient eligibility is determined. Now, during the next few slides, I will discuss whether you'll need to correct or appeal the claim. After reviewing your RA, you're going to need to choose your action. So for an unprocessable claim or a rejected claim, you need to fix the error and resubmit the claim to Medicare. If the claim line or claim denied, there may be multiple actions to choose from. You may be able to simply resubmit that claim or service line. You might use the clerical error reopening or CER process to fix a clerical error, and CMS defines a clerical error as human or mechanical errors on the part of the provider or the contractor. Another action to consider is an appeal. The remittance advice will provide appeal rights. I'll discuss appeals just a bit later in this webinar. Now, if you are a registered user of our secure portal, called the SecureNet Access Portal, or SNAP for short, you can render or request a clerical error reopening, or you can request an appeal. This is one of our self-service tools, and we offer self-service tools to providers because they really do offer the most efficiencies. They save time and money. Our portal user manual provides illustrations and step-by-step instructions on how to use the portal features. And I'm going to open the WPS website here and pull it over so you can take a look at it, and I'll just show you where you can find that portal user manual. Right, coming right at you. I'm going to show you our home page on our website. There's a couple ways you can find that portal user manual. I'm trying to make it a little bigger here for you. All right, if you're looking at the home page of the WPS website, you will see right up here in this blue box near the top of the page where, if you're a registered user of SecureNet Access Portal, you can log in and access a lot of information pertaining to your claims. You can also register to become a user of the SNAP, the SecureNet Access Portal. Here is a link to that portal user manual that I was talking about. Now, if you don't see it here near the top of the page, scroll down to the bottom of any WPS web page, and you will see under Educational Opportunities in the big blue box a link to the portal user manual. Again, illustrations, step-by-step instructions to use the SecureNet Access Portal. Okay, here is a little bit more information about appeals that I promised to cover. For claim denials, most often, with few exceptions, you can request an appeal. There are 5 levels of appeal. There is only one level of appeal. It is the very first one, called the redetermination, that is rendered by the MAC, the Medicare Administrative Contractor. All 5 levels of appeal have time limits that you have to file the request, and the time limits begin the day that remittance advice is generated and sent. There is also time limits for the contractors to complete that appeal request. There are 2 levels of appeals, level 3 and level 5. They're listed here on this slide. You can see it's the ALJ hearing and the federal court review that have an amount in controversy. And what an amount in controversy, or AIC, is a dollar threshold that applies. It's a minimum amount that there must be that you dispute in order to submit for that level of appeal. And maybe it will be more understandable when I move to this slide. This is some appeals resources for you. I placed them here while I'm covering appeals versus at the end of the presentation materials. But how to appeal a claim determination is a resource available on our website. It tells you how to appeal. It tells you about the 5 levels. It tells you time frames, the amounts in controversy, and so on and so forth. It also tells you where you need to submit your appeal when you're disputing a claim decision made by the MAC, the Medicare Administrative Contractor, or another level of appeal, one of the other contractors that are rendering those appeal decisions. One of my personal favorites, though, is the next bullet here you see on this slide, the next resource. It is CMS's fee-for-service appeals process flowchart, and you can just see a picture of it over a graphic over on the right side. It is something that is updated annually, and I'm going to just click on this embedded link here and open it up and show it to you because I think this is just such a fantastic what do I want to say, publication that CMS makes, updates yearly. If you look here way at the bottom of the flowchart, you'll see that the last sentence reads, "This chart," or the chart, "reflects the amounts for calendar year 2025. So if you're using this chart or referring to it, make certain when 2026 begins, it's not that far away, that you are looking at the correct published version of this flowchart. You will see on the left side of this resource the standard process for parts A and B. On the right side is the expedited process that applies for some part A only. Today's webinar was advertised as part B, so we're talking about the standard process only. You will see the initial claim determination here in this flowchart, the first step, the max determination. You have 120 days to file the first level of appeal, which is called the redetermination rendered by the MAC. The MAC has 60 days to make their decision. If your decision is not fully favorable or not favorable, you have 180 days to file the second level of appeal, which is done by the qualified independent contractor. It's called the reconsideration. They have 60 days to render their decision. So you can see first level appeal, second level of appeal, here's third, followed by the fourth and the fifth. I like this at a glance version, if you will, that shows these 5 levels of appeal and the time frames. There's also on this flowchart the amounts in controversy for level 3, which is right here, and then level 5, which is judicial review. And if you look here, the amount in controversy, or the AIC for a level 3 appeal, is greater than or equal to $190, and these amounts can change from year to year. So again, it's important to make certain that you're looking at the correct version of this flowchart. CMS has been publishing this for years. I hope they continue because, like I said, it is one of my favorites. And here then is that AIC for federal district court equal to or greater than $1,900. Well, that's a lot of money. That's a big amount. You can combine similarly denied services in order to reach this threshold when you're submitting appeals to Medicare. So it can be more than one claim that you use to reach that threshold. All right, folks, let's get back to the presentation. At this point is the portion of the webinar that focuses on that data, and that data is important. CMS wants us to share the results of our data when we analyze data so that we can prevent these rejections and denials from happening in the future. We use a tool that we call the data dashboard, the claims data dashboard, in order to pull the data that I do plan to share with you today. And this dashboard is an interactive tool that's designed by our data analysts here at WPS. Their department is called Insight. They are responsible for mining data. They work closely with both policy and medical review to monitor trends identified for rejected claims and denied claims. I'll show you an example of that in a little bit. Among other tasks and responsibilities that they have built this dashboard that people like Bailey and me use to analyze the data, determine what kind of education we need to create and provide for our provider community. There are different ways for us to view that data. We can look at a particular state or jurisdiction, whether it be jurisdiction 5, Iowa, Kansas, Missouri, Nebraska, or jurisdiction 8, which is Indiana and Michigan. We can look at part A, we can look at part B, we can look by reason. Why are the claims rejecting or denying? We can look at the codes that are rejecting or denying, and we can look at specialty. And that's why it was so important that I use this tool for today's webinar so that I could identify to you or reveal to you why we are most often rejecting your specialty claims, your specialty 37 pediatric medicine claims. And of course, we can look at trending, which I touched upon just a little bit earlier. So then here are the data slicers that were used. And the data slicers is a term that is used by our data team. And really, if you can envision a drop-down menu with different choices to make, that's a data slicer. I mean, that's how data slicers work. We look at this interactive tool, which I can't show you the tool itself because it is inside our secure environment. I can't get to it when I'm presenting a live webinar. I can't show you within our secure system, only outside of that. I looked at all states in WPS jurisdictions 5 and 8, so all 6 states, and some, it's only part B, so 6 states. Specialty 37, pediatric medicine. Now, some of you might be wondering, why does Mary keep talking about specialty code 37? What does that mean? For those of you that don't know, or those of you that are new to Medicare, it is a 2-digit code that's assigned to a WPS provider when they enroll with WPS. Now, during enrollment, a provider or most providers can self-designate their primary specialty, while they can designate a secondary specialty or even a tertiary specialty. It is only that primary specialty that we use, that one designated, that is used during initial claim processing. Now, there are some situations where a provider will request an appeal and they'll stipulate, I have a secondary specialty of electrophysiology. And then Medicare can consider payment on that claim. But the computer logic used during claims processing, when those edits and audits are applied to a claim or a claim line, is going to view that specialty code, primary specialty code, most often self-designated, sometimes not, as the one used during initial claim processing. So I used specialty 37, pediatric medicine, to pull data for today. Now the claim submission dates that I looked at when I pulled claims, when I looked at or not pulled claims, but when I looked at the data prepared by Insight in that data dashboard, was submission dates February 1 of 2025 through April 30 of 2025. The last date refreshed was May 8th of 2025. We look at our submission dates at 3 months at a time, and it's on a rolling basis. So February will drop off and then May will add when the data is refreshed in June. You might wonder why I didn't use June data. It's because I had to prepare and get this presentation through a review and approval process, and that's a time consuming thing. So I did this and looked at the data in May of 2025. And here are the most common rejection reasons for specialty 37 claims for WPS submitted claims. You'll notice some numbers behind each of these reasons, these rejection reasons. That is the number of claim lines. Now, for your specialty, those providers who self-designated 37 as their primary specialty, the most common rejection reason for claim rejections is that the rendering physician number was invalid or missing. Remember, we're talking rejections now. You got to fix it, resubmit it, not denial. So most of these, I think you would agree, are pretty straightforward. You read them, you know what you need to do to fix it or submit it. You need to submit that new claim. Let's take a look at the second most common rejection reason: description of the service missing. There's no description of the service on the claim, 76 rejections. Missing, incomplete, invalid ordering primary identifier. For certain services, there must be an ordering identifier or ordering provider identifier on the claim. If it's missing, your claim will reject, or that claim line will reject. 76. Next is invalid or missing modifier, 18. Rejections: incomplete, invalid plan information for other insurance. What this means is that you told us on your claim that another insurance is primary to Medicare, but you didn't give us all of the other information that you need to place on that claim, which is situational. If there's another insurance that's primary, then there are other items on the claim you need to fill out in order to help us know who that other insurance is. No submitted charges billed, 6 rejections. Missing procedure modifier, 12, and place of service conflicts with the procedure code. So for an example there would be if you used a place of service 11 for office on your claim, but the procedure code, the CPT code or HCPCS code, is one that is identifying an inpatient service, for example. All right, I thought in addition to telling you the reasons why your specialty's claims are rejecting by Medicare, WPS Medicare that is, I thought it would be interesting to take a look at what are the top CPT or HCPCS codes that we are rejecting for your specialty, and here they are. The first is 99499, and this is an unlisted evaluation and management or E&M service. It is a non-specific code that indicates that an E&M service was done, but it doesn't fall under any other existing E&M code. The reason why we're rejecting your claims or this specialty's claims is that the description of the service is missing. When you report an NOC code or a not otherwise classified code on a claim, you have to describe to us what it is you're billing for. And there is claim form instructions that CMS has published that tell you where you need to put what in order to do that. It is item 19 of a paper claim form or the electronic equivalent. Now I talk about paper claim form. It's easy to envision that red and white paper claim form, that CMS 1500. But I know that many of you submit claims electronically. When you are on the WPS website, if you are on the home page, you will notice over on the right-hand side some quick links. I mentioned to you earlier that our EDI, or Electronic Data Interchange staff, have their own website. Right here, EDI shows a quick link to that website. So if you click there, you actually leave WPS Medicare's or our Medicare website and you go to our EDI page. Because we have other lines of business, scroll down and you'll need to choose your line of business. We have Medicare, we have TRICARE, and we have our WPS health plan. Right here is the Medicare EDI box that you need to choose in order to reach all things Medicare EDI for WPS. I talked about those companion guides earlier, used when you initially submit your claim, those pre-pass edits, they are here. But what I want to show you right now is this crosswalk. A lot of people don't know about it and their eyes are opened when I show this. So I'm going to choose the CMS 1500, which is the paper claim form, to the 5010 crosswalk, which is the ANSI 837 current version electronic claim that we're using. This is a crosswalk that crosswalks the paper claim to an electronic claim. So for example, I talked about that red and white claim form. If you can envision that red and white CMS 1500 claim form, it has item 1, it has item 2, item 3, so on and so forth. If you look in this crosswalk in the first column, it shows you the item on the paper claim form. So in item number 1 is your type of health insurance. This crosswalk shows you where that same information appears or is placed on that electronic claim. Tells you the data element description and requirements for that version 5010. Item 19 on a paper claim form is one that is used for many items. So you'll see many lines here on this crosswalk that pertain to item 19. And of course it tells you where it's placed on that electronic form. One thing I want to point out to you is the status column right here. Well, I'm trying to get it. It's up here. The status column, the second to the last column from the right. Notice those S's and R's. R means that the data element is required in order for us to process the claim, and the S means that it is situational. So R is required. So it makes sense that the Medicare beneficiary identifier is required on the claim form. So you're going to see an R in this column. I talked earlier about rejections and that some services are being rejected for your specialty because you told us there's an insurance primary to Medicare, but you didn't fill in the rest of the blanks. This is what I'm talking about exactly here. For those rest of those blanks, you're going to see S in the status code column, and this isn't specifically that item. I'm just showing you an example of the status code column. S is a data element that must be completed, but only if other conditions exist. So right here, if the insured differs from the patient or if the insured's name, then the insured's name has to be entered on the claim. There's a good example for you. But another example is that situation where there is another insurance primary to Medicare, but you gotta add all of the other identifying information that's then situational and should be on the claim. What happens if that required element is missing from the claim? We've talked about it. The claim is unprocessable. Okay, so no submitted charges, description of service missing, 99499. The second most common rejected code is 71046. This is the X-ray exam of the chest, specifically a 2-view chest X-ray. Rendering physician number invalid or missing. Okay, who did that service? Who is billing for the chest X-ray? Needs to be on the claim. If it's not there, it's rejected. 99213, 99214 are both E&M codes, and you can see the top 3 most common reasons for rejection for these E&M service office visits are a little bit different. 99213, place of service conflicts with the procedure code. The health insurance claim number and name do not match. It has to match exactly. Make sure that name on the card matches the number or that beneficiary identifier that is now submitted on the claim. You'll see this old acronym here. This is the way these reasons print out on these internal reports when we're looking at the data or on the remittance advice. So I placed them here on these slides exactly as they printed out on that claims that tool that I used, the claims information, those rejections and denials that is provided to us by our insight folks, the data folks. Incomplete, invalid plan information for other insurance. That is just what I talked about, those things that are situational that you might have to fill out. Make sure you're placing the information that is needed on your claim. Place the service conflicts with procedure code. That one's the same. Field 11 of the HCFA 1500, now known as the CMS 1500. The reason HCFA's here is because that's the way it prints out when we are looking at that data file, that data dashboard, or at the remittance notice. So field 11, well, what is that used for? Field 11 is the field that is used, and again, we can look at that field here on the crosswalk here. I'll pull it back open. Field 11, what's in 11? 11 is where you need to tell us if another insurance is primary to Medicare or not. And you can't leave it blank. You have to place the word none there if there is no other insurance primary to Medicare. So that must be completed on every single claim. Place of service conflicts with procedure code. I see I've got that on there twice, folks. I've just noticed that. I will take a look at that following today's webinar, and I will give you the third reason why 99214 is most commonly rejected. I apologize for that. Remember my disclaimer. Something could change. I'll get that information to you. 76705 is ultrasound service. Rendering physician number is invalid or missing. Maybe it was keyed wrong. Maybe it's not there at all. So that's what you need to check. 96372 is on here, and this is the administration of a therapeutic or prophylactic or diagnostic injection. Those that are administered sub-Q or subcutaneous and intramuscular, those routes. For that, the most common rejection, and you'll notice we're down to one here because it was the only reason why we rejected that particular code, 76705, and all three of these here on this slide. But field 11 of the 1500 must be completed, or the electronic equivalent. 36415, of course, is that venipuncture code, and we're rejecting that for your specialty because there is an incomplete or invalid ordering primary identifier. All right, so we talked about rejections, very different from denials. You need to fix it, resubmit it. Now here are the top most common reasons for denials and the number of claim lines that we've denied for that service period, those data slicers that I identified to you earlier, those that I looked at on the dashboard. The number one reason why your claims were denied, 56 of them, is collection of fee-for-service during periods of managed care. Remember I talked about cryptic? That one's a little cryptic. I actually had to check with our system folks to see, does this really mean what I think it meant? And what this means is that the beneficiary has chosen or elected a managed care plan, which is a form of Medicare Part C. Those claims do not get submitted to WPS, they go to the Part C plan. These were service lines or claims that were denied because the patient had managed care, should not have been paid for by Medicare, or should not be submitted to Medicare. Medicare will not pay for this service for this condition. What that means, folks, or translates to, is medical necessity. So that would be an indicator to me, if I saw this on an RA, to look for a policy. Or look in one of CMS internet-only manuals to see why Medicare will not pay for that service for that condition. Maybe there is another code that would make it payable. Maybe the wrong code was reported. Maybe the code was transposed. So in that case, if you're going to submit or request an appeal for this service, you would need to submit the correct ICD-10 code, thereby making the service payable based on your documentation, of course. Another collection of fee-for-service period during periods of managed care, you'll see 72 there. Sometimes the way the claims edits work, there are different numbered edits that really are looking for this the same kind of a denial. So we assign internally different numbers to these edits, and what happened here is that one edit was 56 denials, the other edit was 72 denials. So add them together, still making that the number one reason why your claims are denying. Duplicate charge paid, insert a date on claim, insert that internal control number. Duplicate claims continue to be problematic for WPS and for all other MACs alike. We continue every single day to deny thousands of claim lines or claims because they are duplicates. Maybe it's a duplicate of a claim that's already paid. Maybe it's a duplicate of a claim that's currently in the processing system. Maybe it's another form of a duplicate. Either way, that represents a cost to both the provider and to the Medicare Trust Fund. So we need to eliminate all of these duplicate denials. We need to do what we can to bring those numbers down, save costs for both Medicare program and for the provider community. We'll cover that in just a little bit. We'll talk about how to do that or suggestions to avoid those denials. Next, claim must be sent to the EGHP. EGHP stands for Employer Group Health Plan. So this means that that beneficiary is covered by an employer group health plan, and it has to go there first before Medicare can consider payment. In other words, the employer group health plan is primary. Expenses incurred prior to coverage. 38 rejections, or excuse me, got to correct myself there, denials, not rejections. All right, so you need to look at the date and what service is being billed, the expenses prior to coverage. So you would need to check eligibility in order to make certain that the date of service is being billed correctly if you think the service is covered. Now let's take a look at the codes. 99213, once again, E&M. This code is the #1 denied code for your specialty. It doesn't surprise me when I'm facilitating these webinars to see E&M codes pop up for many of the specialties, depending on the specialty, of course, and whether or not the provider is eligible to bill an E&M service. But 40% of all claims submitted to Medicare include an E&M code or an E&M charge. So no big surprise to see these popping up. Collection of fee for service during periods of managed care. Information does not support need of this item or service. That is a form of medical necessity. Claim must be sent to the employer group health plan or large group health plan first. In other words, Medicare secondary, send it someplace else. Duplicate, right there. Here's one. The time limit for filing your claim is expired. And I want to point this one out because this one is kind of hitting us, not just your specialty, but a lot of other specialties. So one of my colleagues has been running a webinar or been offering a webinar from time to time to talk about timely filing. We do have an article on our website that speaks to timely filing, and I've included this in the resources at the end of your presentation materials that speaks to timely filing. This talks about patient responsibility for claims denied for late filing. You can only hold them liable for 20% of what we would have paid had the claim been timely. Talks about denied claims that are not filed within the time limit due to a third-party error. And this is really what I wanted to point out to you, because we get this question a lot. Providers often ask us to reopen a claim. Whoops, I went to the claims processing manual. You can see the link is right there. So if you click on it, you're going to open the IOM, and that's the citation that says this. But we often get questions from providers or requests to reopen a claim for timely filing because an insurer came back and recouped their payment, even as far as 7 years ago or however many years ago. CMS, in their internet-only manual, and it is right here, I actually just popped it open, says that a third-party error in making a primary payment determination doesn't constitute good cause for the purposes of reopening an initial claim determination or redetermination when Medicare processed the claim in accordance with the information in the system of records or on the claim form. In other words, for this type of error, Medicare is not going to waive timely filing. CMS does not allow us to do that. So this is where it says that. Now, there may be situations where you have a valid reason why the claim was not filed timely. And this explains how to file that waiver to extend that timely filing limit so that we can reopen and pay the claim. And of course, we have the addresses here because you do need to send a request to our claims manager. You'll notice this is Indiana and Michigan, and that is because I am currently, look on this green button, highlight here under J8 MAC Part B. If you're looking for J5 MAC Part B, you can easily toggle back and forth. Just click on J5 MAC, and then the addresses that will show will be our J5 addresses. Okay. All right, moving on, and I'm going to pick up speed here because we're getting shorter on time. Similarly, 99214 is denying for the same reason. This one, though, has a new one popping up. One visit or consult per doctor per day. It is an E&M service. We need to look at E&M guidelines. There is only one visit or consult per doctor per day allowed by Medicare. If more than one claim is submitted for this visit or consult for the doctor per day, it's going to be denied, that second one, or the second one received. Another new one here that's popping up is this, I apologize, this physician or supplier is not eligible to receive payment. You're going to need to check provider enrollment files in that. G2211 is an add-on code. This service is only payable when billed with an E&M service. If it's billed with another service, it's not going to be paid. It's going to be denied, which is what's happening here. This claim or this code is fairly new yet, so some of the denials that it's picking up is because it is newer, but we do have a lot of education available that speaks to this code. We have held previous webinars. You can find recordings of those out on our YouTube channel. CMS also has education for this code, and claim must be sent to the EGHP first is why it's denying. 99232 is a hospital inpatient code or observation care per day. It's the evaluation and management of a patient. The reason why this is denying is the provider certification has expired. You need to look to provider enrollment. Charges incurred for that patient during an incarcerated period. The patient was in jail or in Huber. At the time, there are various definitions, if you will, of an incarcerated period. If you're not familiar with those, again, one of my colleagues has been offering education because we look at this data and we're seeing this is happening, so we need to avoid these denials. So we have YouTube videos available, or they're recordings of previous webinars. Maybe there's only one out there because they likely get rid of or delete rather the oldest version and keep only the newest version out there. So look to the YouTube channel. Again, it'll be listed in your resources later. Expenses incurred prior to coverage. Make sure that you're looking at eligibility dates. And then again, there's that duplicate. Sorry, I'm getting trigger happy here with my mouse and moving ahead when I shouldn't be. J1642 is used to bill for the injection of heparin, sodium, per 10 units. 36416 is billed for the collection of the capillary blood specimen, like a finger stick or a heel or an ear stick. These codes aren't separately payable. They're bundled codes, so separate payable may not be made, which is why we're denying them. You know, and as we're educating, we know that these services are set up that they're not separately billable. And the expectation is that although you don't need to submit a claim or a service that's not covered by Medicare, we understand that sometimes you have to submit it to us so that another supplemental provider or payer rather will get that claim and consider that service for payment. So when we're analyzing the data, we look at things like that. Is it correct that we're denying this because separate payment can not be made? Yes, but it doesn't mean that the provider is doing anything wrong either. The 96372 is reported for the administration of therapeutic, prophylactic, or diagnostic injection. That one also hit on the Rejections, dupes, look at that, two of them. The first two reasons they're denied is for dupes. What's happening is folks, because when the service gets denied, sometimes they just submit another claim without checking to see if we've processed the previous claim. If you're using a billing service set up to bill on a cycle every 30 days, tell them to stop doing that. It is abusive. You need to do your due diligence to see the status of that previous claim. Don't just submit a new charge. Physician or supplier not eligible to receive payment. There you need to look at why that physician or supplier isn't eligible to receive payment. When was their effective date? So that would be a provider enrollment issue. And then again, back to collection of fee for service during periods of managed care. Here is a trending example. I mentioned to you that we look at trends. Service units of service are exceeded. This, folks, is that medically unlikely edits. Now, this didn't hit your top or your most common denials, but I did want to show you an example of trending. So we can also view on the dashboard, we can look at the current 3-month count for a denial reason, 58. You can look at what the prior 3 months were, 27. That's a 31 claim difference, representing a 115% increase. So as we're looking at these trending of data, these reports, we can see what it is we need to focus on for our education. Besides that, we also want to focus on what you want, what you need. And one way you can let us know your wants and needs is for you to complete a brief survey that we are asking you to complete following this event today, and tell us what it is you want to hear about. You know, what do you want WPS to schedule webinars on and cover? So this would be MUEs, which is part of the National Correct Coding Initiative edit. Modifier fixes. Make sure that if a modifier is required, it's there. Make sure that the modifier goes with that procedure code, that it's valid, that data service. I'm going to move through these quickly because they are pretty straightforward. Eligibility fixes. Make sure that patient name and their Medicare beneficiary identifier exactly match. If there's a middle initial on the patient's Medicare card, make sure that middle initial is on the claim form. Submit services to the correct payer. Is the beneficiary eligible for Medicare because he or she has selected a Part C plan? If so, the claim doesn't come to Medicare. It goes to the Part C plan. Similarly, if it's a railroad retiree or a former mine worker, the claims need to be submitted elsewhere, not to WPS. So this would be a fix and resubmit situation. Rejected claims send to the Railroad Board or United Mine Workers of America. Provider number fixes. You know, make sure you're keying those provider numbers correctly. Make certain your provider enrollment records are up to date. If you're part of a group, make sure that the rendering provider is associated with the billing provider or with that group on the claim form, and make sure that if required, that ordering provider information is entered on the claim. This speaks to the duplicate denials I mentioned to you. Don't just automatically resubmit prior to establishing status of the first claim that came through. Make sure you're billing appropriately. And for some services, you can add a modifier to tell Medicare, this isn't a dupe, this is a repeat service by the provider and it was medically necessary. MSP, there were several denials today due to Medicare as a secondary payer, or that the claim should go elsewhere. I have included links to some really great publications and a lot of help here. Here's a YouTube playlist we have available out on our YouTube channel. I talked about that a few times a day. So this takes you there easily from those prepared prepared presentation materials that you had an opportunity to download. Here is how you can avoid National Correct Coding Initiative edit denials, including bundling. Those procedure to procedure code edits will tell you which codes bundle into others. I also showed you trending for the medically unlikely services, that this service exceeds the number of units that are allowed. That would be the MUE edits. So I've included those as resources. More resources. These are the IOM instructions on how to fill out a claim form. What goes in item 1, what goes in item 2, what goes in item 3. And of course, that would be the paper claim forms. Well, there's also the electronic claim form here, but I have included the link to the crosswalk also on this slide, and I showed you that earlier. This talks about a couple of self-service tools, the IVR and our Secure Net Access portal that I talked about. These offer claim status, details, depending on which one you use. You can even find eligibility on SNAP. 24 hours a day, 7 days a week. I'm just kind of toggling back and forth. There is limited functionality outside of normal business hours, and for both the portal user, or excuse me, the portal and the interactive voice system, that's the system where you use voice or telephone keypad to get information. There are instructions available in the operating guide or in the portal user manual. Resources. We have a resource on our website called How to Correct a Rejected Claim. It tells you how to send it in, where to send it in, or how to correct it. Sometimes you can use that clerical error reopening process. We have an article that talks about that. But we talked earlier, or I talked earlier in this webinar about reason or remark codes. Go to this resource. It lists reason and remark codes. Match those up to what you see on your remittance advice, and it tells you right here in this resource how to correct it. Similarly, we do the same thing for denials. Look for that reason and remark code in this resource on our website. Out on our website in this resource, we actually categorize the denials. So we have bundling denials, we have duplicate denials, we have entitlement denials, and we have those reason and remark codes. Match those up to reason and remark codes on your remittance notice so that you can fix or correct those denials rather. Here's our website, how to correct that clerical error reopening. Gives you examples. What can you do a clerical reopening on to fix, to reopen? What can't you? Modifiers webpage. Some of the rejections or denials related to modifiers. We have modifier fact sheets for all kinds of modifiers. Says, can you use it with this code? Yes or no. What's the appropriate use? What's the inappropriate use? I showed you the timely filing of claims article. It's right there, the link. Live events webpage, future education. Encore presentations or recording of past education. Some of the denials had to do with place of service doesn't match the procedure code. So here's the place of service code list. Again, I've listed the YouTube channel with links to information about the Advantage plans. We can't really answer a lot of questions about Medicare Advantage plan because we're not the plan. We are Part A and Part B. So very often when you call customer service and you say, I have a question, my patient is a Medicare Advantage plan, they have XYZ plan, they say, we can't help you. You need to call the plan. That's because they are different than traditional or original Medicare. I mentioned to you the incarcerated beneficiary denials. Right here is a link to CMS's website article on that. CMS's other resources, checking Medicare eligibility. This is an interactive map. When you open, it actually shows you a map of the U.S. Open on my other screen. Pull it open for you. You can click on any state and it tells you where to send what claims. For Railroad Board, where do you send the claims? For the Medicare Administrative Contractor, where do you submit the claims? Who is the RAC in any one of these states? So it is a contractor directory, really nice tool. Physician relative value files, there is a column on this file, this physician fee service RVF file. It is a status code. If there is a B in the status code column, that is a service, and all of these services are listed by CPT or HCPCS codes on this file. If there's a B in the status code column, that means it's bundled. You cannot add a modifier to unbundle payment for that particular item or service ever. So B means bundled, always bundled. I talked about ordering and referring, and some of the claims are denying because there was no ordering provider. This is a CMS file. Again, sorry about that. This is a CMS file out on their website where you can do a search by provider name to tell you whether that particular provider is eligible to order or refer a service. It also gives you their national provider identifier. More CMS resources. I talked about G2211. That's a new code. It's an add-on code. You have to bill it with an E&M. You can't bill it with another code. That's the resource for that. The coverage database is a searchable national depository of national and local coverage determinations that will tell you Medicare will pay for this item or service, but only when you meet these parameters. The coding and billing guidelines that are the companion document that go with the policy will give you the codes, both the CPT or HCPCS codes, some policies, not all of them, and also the diagnosis codes that are payable for that particular item or service. More incarcerated beneficiary information. This is where I would normally ask for questions and answers, but unfortunately I'm short on time. I will go to the items in the chat or the questions in the chat. I will make certain I answer them, and I'll tell you in just a minute how for 7 days you can send presentation related questions to me. I want to tell you that we have made some changes to our education. It is based on the comments that you have given us when submitting your surveys to us. We've added chapters to YouTube. This means you can look at a list and it tells you jump here or there to go and get the information that you are looking for in that video. So if you're looking for rejections in the video that I'm going to make from this webinar today, you'll just be able to go to the rejections chapter. If you're looking for denials, you go to denials. If you're looking for resources, you go to that chapter. We've also added training indicators to our webinar descriptions, so you know if that particular webinar or that particular session that we're offering pertains to you. More about training indicators on our website. Now, certificates of achievement. It's called a certificate of achievement, but it's really an email. In a few minutes, you will receive an automated email. It's coming from WebEx, not from WPS. It will thank you for attending. If you need CEUs, this email is going to have verbiage in it like what you see on the bottom here in the red box. It's not a specific special certificate. It's verbiage within that email, and it's going to say you completed our training today. This is what you need to make a copy of and submit to an accrediting body or organization if you are seeking CEUs from them. We don't give CEUs. We arrange for this email to be sent to you with this verbiage that you use to request those continuing education units. If you joined by phone only today, in other words, if you can see me now, or you can hear me now, but you don't see the slides, you will not receive this automated version. What you need to do is send an email to wps.gha.education@wpsic.com. That information is in the presentation handouts. You can send an email to us, give us your name. Well, we'll have your name from the email. Give us the name of this webinar, today's date, and the telephone number you called in from, and we will arrange to get you a certificate of achievement. Now, we didn't have time for questions today, but I promise you I will answer them. You have 7 days from today to send questions by noon to our education mailbox. The email address is here. Put today's topic in the subject line. Go ahead and feel free to abbreviate. Claim specific questions, though, remember, do need to go to customer service. They can look at claim history. I cannot. I do not have access to any claim specific information, but follow-up questions are welcome. I will send a response directly to you, or I will make a list of questions and answers and send it to everyone. We do have a survey available, and we really want you to take just a couple of minutes, please, to complete the survey. Tell us what you like. Tell us what we can do better. Give us topics or ideas for future education. If you want me to expand on something I touched on today, let me know, and I'll consider creating more education based on your wants and needs. This is so important. CMS and WPS look at these. I did a presentation a while back for a partner. My manager actually had 2 vice presidents call her about those survey results. People are looking at these surveys. CMS is looking at them. WPS is looking at them. I told you about chapters and training indicators. Those just didn't happen. Those happen because you told us you want them to happen. So we give you one last opportunity. If you've not already taken the survey, you will, when you leave this webinar today, see the white box at the bottom with the yellow triangle on top. And that gives you one last opportunity. That will take you out to the CMS website where you can take that survey. I am running over just a little bit, folks. I am so sorry. I had so much information to share with you today. We know you're busy. Your time's important, so I'm going to make this short. On behalf of myself and Bailey and all of Outreach and Education, thank you so much for joining us. We do look forward to those survey comments, and we hope to have you join us for future events. You may now disconnect. Thank you so much.